So is this where we left off? I think so. Any questions before we get going? Continue on? Nothing at all. Do I feel better? Do any of us feel better?
Not cynical at all.
That's an existential question I'm not prepared to answer at this moment. Am I recovered? Mostly. So. Anyway, let's continue. I was reading a article the other day. I found this is interesting. This will pertain to a topic today that we'll cover. But there was a article that was talking about diarrhea in individuals, and it said there's actually a genetic link to it. It runs in your genes. Okay. Now everyone's in the proper mindset. Oh, you got it? There you go. Yes. Okay, let's continue on. So let's talk about peptic ulcer disease. A lot of this is going to pertain to what we talked about with H2 blockers and proton pump inhibitors, whatnot. What are kind of our main causes for peptic ulcer disease? NSAIDs are a big one, and H. pylori the other one, right? Do you guys ever read up on the history of H. pylori, how they discovered it? The Australian doctor who got a Nobel Prize from this is actually quite interesting if you go check it out. No one believed him that he thought it could be an infectious cause, so he drank H. pylori, gave himself an ulcer, then drank antibiotics and fixed it. So it was like kind of an interesting N of one sort of study there. But anyway, so obviously treatment's going to be pretty different between those two. We'll talk about those individually and how we can kind of facilitate the healing that occurs there. But certainly stress can be a big factor here. Why would stress lead to peptic ulcers? Because what? What do you produce when you're really stressed out? Cortisol, right? You're all stressing out and producing a lot of cortisol. What does that do to prostaglandin production? Decreases it. What does that do to your protective barrier? Decreases as well, right? So it kind of makes sense why we would see that. And that's a lot what I talked about, that stress-related ulcers in like ICU patients I was mentioning before, and using PPIs to help limit some of that stress injury that you can see there. You can decrease acid production, decrease the damage done to the lining, and that will make sense when we talk about that again a little bit later on there. But certainly anyone who's on chronic steroids can also see similar things happen here due to that same sort of pathophysiology, right? Anyway, so certainly we can distinguish between duodenal and gastric ulcers there. For my purposes, I'm not going to get really big into the differentiation between the two. We're more looking at what's the underlying cause for it, because that'll dictate kind of how we get around that, how we treat it. Because obviously, certain things, maybe if it's an NSAID-induced ulcer, how do you treat that? You stop giving the NSAIDs, right? So sometimes it's pretty obvious, but we'll look at like particular H. pylori, how we can treat that more specifically with type of antibiotics and things like that, right? Obviously, we know risk factors. Certainly smoking can increase this. Also, we talked about alcohol ingestion yesterday. That can also help to kind of speed that along for sure. But sometimes it's just genetic predisposition. Stress can also play a big role there as well. So, as I mentioned, the treatment's obviously going to be predicated on what the actual cause for it's going to be. Sometimes it could be the initial presentation. If it's more recurrent, that can also be a factor as well. So for instance, if it's like a recurrent one due to H. pylori, then that will dictate sort of what kind of regimen we give in terms of the antibiotics we're choosing, etc. And then also look for any kind of complications. Is there bleeding? Has there been a perforation, etc. Right? For the most part, we're going to see in terms of just conventional management, PPIs and H2 blockers are going to be sort of your go-to. And again, looking at the heal time, 4 to 8 weeks, so it can be pretty long in terms of that. Which ones do you think could be more potent at helping with the healing? PPIs, obviously, right? So they just pack way more punch in terms of decreasing acid production than the H2 blockers. Why is that? Right, so they're irreversible inhibitors of the actual pump making the acid itself versus H2 blockers. There's other ways to produce acid, right? There's still gastrin and there's still other things, acetylcholine, other things like that. So again, it's just affecting kind of the end of the line, so to speak. So that's why they're more potent. And typically you'll see that healing times will be shorter if you are giving a PPI versus an H2 blocker. But some other trade-offs there, it's more expensive, things like that. But most patients, if they have H. pylori, but maybe it's not caught, maybe it's not diagnosed, you treat them conventionally with just like a PPI, they will relapse for sure, because unless you eradicate the actual infection, it's just going to come right back in those cases. So obviously if you can eliminate or reduce physiologic stress, that's going to help out, but sometimes that may not be possible. Sometimes you're just signing yourself up for 27 months of stress. What are you going to do about it, right? Sometimes that happens. Obviously, if there's certain food triggers, you can eat smaller, more frequent meals, et cetera, et cetera. In terms of NSAIDs, so there's a couple of things we can do there. In some cases, if you can avoid NSAIDs altogether, it's going to be preferential, right? But they still need some kind of pain relief. What could we use instead? So yeah, so we can talk about using like a COX-2 selective agent there. We'll get into more details on that in the ortho section later on. What else can you do? Could I use something like acetaminophen instead?
Yes.
Perhaps, yes, that could be an option in some patients there. I heard some people talk about misoprostol. What is that? There's that Cytotec. It's a synthetic prostaglandin, right? So you can replace the prostaglandins that your body is not producing because of the NSAID there. So that could be one thing. So we talked about a couple different options that could be there. Certainly administering food may help in some cases. And if you can stop the smoking or alcohol that's going along with that, that's kind of aggravating, that can also be very beneficial as well. So we talked about our different agents here. Now, again, what was kind of the downsides of antacids? How long do they work? Very short acting, right? Because again, once they neutralize the acid, once they've lost that buffering capacity, they're kind of done, right? So they're good for more sort of acute episodes, right? They're not going to be for that more long-term sort of control there. When should you give a PPI? When's it most active, or when does it work the best? When the pumps are actively working, right? So when does that? You're gonna have a meal, right? Right before you eat. So again, that's typically so if you can give it as before breakfast, something like that, it's obviously going to be the best thing around that time. And again, we'll talk about each of those and where they're going to kind of fit in, and we'll talk about the drugs to eliminate H. pylori. You probably already covered that with Professor who's covering it? Sullivan. I'm used to calling her by her first name. So, anywho. Oh, by the way, I also tracked down, so you know how like sometimes like you hear the same people talk over and over again and then you pick up their vocal tics, right? I found out where I picked up the anywho from, and it was a podcast, but I'm not going to tell you which podcast because then that would give away some of my deep, dark, secret hobbies, I'll say. I don't want to do that at this point, but I did track it down. Anywho, getting back to it. So remember, for a long time, all we had were our H2 blockers, and so that is certainly effective, but again, you're going to typically rely on longer treatment times, probably closer to that 6 to 8 week sort of time frame. They're certainly more effective than antacids. Any of them are going to work, but which ones are we going to avoid? Cimetidine, and why? It's a potent 3A4 inducer or inhibitor? Inhibitor. Remember, it's a CYP3A4 inhibitor. That's why we don't do cimetidine. So it's important to know not to give cimetidine. It's also important to know why we don't do that, right? Because again, what type of drug interactions would you run into? Obviously, the levels of effective drugs would increase, right? And that can cause too much of an effect. I remember I talked about that lady who took the loperamide plus the cimetidine, caused very dramatic toxic effects because of that, right? So typically a little bit more cost effective than PPI therapy is going to be. That's kind of changed nowadays now that we have more generic varieties that are available, now that we have some of them that are over the counter now, so it is getting to be a little bit more of an even playing field from that standpoint. We do have liquid and IV formulations though. So when would you choose like an IV H2 blocker or maybe a PPI for these type of patients with an ulcer versus oral treatment? So maybe they're vomiting, right? So again, maybe it's like an acute presentation to say like to the ER, the urgent care, and they're vomiting could be one thing. What else? Why would they be in the ICU? Maybe they had a coma, but just for the ulcer itself. So so they had like a perf or something, right? So again, depending on the presentation, how severe, if they're bleeding, if they've had a perf, anything like that, that would lead you to say, this is a more severe patient. I need to make sure I get good bioavailability. I want quick onset. That's when you're going to typically go more IV. And in some cases, we'll do like continuous drips. We'll do like a Prokinetics drip, or we'll do like a Zantac drip or something occasionally, just in order to make sure we're getting nice, high, consistent levels in order to decrease that acid production. So for instance, like we have IV ranitidine we'll use. We actually had that go on shortage. I don't remember if it was recall or if it was just shortage. And so we ended up switching over to IV famotidine. So that's just what now we use, right? IV Pepcid. When I say recall, what does that mean? So maybe it's like a bad batch and they said, okay, we're going to recall all of this off the shelf. Why do we have recalls? well, to protect people, right? But what happens with those drugs that they require a recall? Could be a lot of different things. Sometimes it has to do with the actual drug formulation itself. So maybe there's a contaminant. Maybe there was actually within the case of like valsartan. Remember we talked about that a little bit. They had a recall because there was a contaminant they thought might cause cancer. In that case there. Sometimes it actually has to do with the actual packaging of the product. So for instance, there's an issue one time with phenytoin, right? Or actually it's phosphonitoin, I should say, that there's actually like glass particulate coming off of the vial that's actually getting into solution, which could cause like an emboli in patients. So sometimes it has to do with actually just the packaging, sometimes it's the drug itself. But there's a lot of causes for that if you're ever curious. Anyway, so yeah, so definitely H2 blockers very effective. Switching to PPIs, look at the treatment time, maybe 2 to 4 weeks. So from that standpoint, a little bit faster, definitely more effective there. And again, we have IV options. Usually IV Prokinetics is probably the most common one I've ever seen. Intercall, remember we were talking about the PPIs. What was the thing in terms of when you're taking them, their dosage forms? Is there anything in particular to remember? How you take it? Remember, don't crush or chew those, right? Because they're actually acid labile. I mean, acid will destroy them. So they have that enteric coating around all those little pellets there. So, and again, antacids are good for as-needed symptoms. We have all these are available. Who might sodium bicarb not be good for? So typically hypertensive patients, right? Because that sodium load is going to cause them to hold on to more water, so you wouldn't want to do that necessarily. Who might aluminum hydroxide not be good for? Something you wouldn't know. It usually doesn't come up too often. We don't absorb a ton of aluminum. Long term, if we were using this as a phosphate binder for patients with like end-stage renal disease, they actually would accumulate it and cause neurotoxicity. But not commonly you'd run into this with these type of patients here. Remember, is aluminum hydroxide going to cause constipation or diarrhea? Remember, that one causes constipation, but we frequently mix it with magnesium hydroxide, which causes diarrhea, right? So that's why you get that offset, that Maalox from Myelanthus sort of combinations there. Calcium carbonate would cause diarrhea or constipation. Constipation, calcium always causes constipation, right? And again, it doesn't really matter which one you go with. Just kind of keep those kind of considerations in mind. They're hypertensive, maybe not the sodium bicarb. That one has like kind of the least buffering capacity, and I see used the least frequently. Probably calcium carbonate is more far and away the most common one. What could be a benefit of using something like Maalox or Myelanthus in that liquid formulation? Has a nice coating effect around the stomach, so that can help out if you have those ulcers there. So that may be something to consider. But again, in terms of overall efficacy, we don't really prefer one over the other. Remember, drug interactions, a lot of these are going to chelate with drugs. So for instance, iron preparations, fluoroquinolones, tetracyclines, that may be important because you may be treating an infectious disease at the same time, right? So looking at H. pylori, so why is H. pylori sort of unique in terms of it causing ulcers? Yeah, so it's able to survive in a relatively sterile environment, right? It's kind of it's a very harsh environment to live in the stomach with the pH is like 2. So it's able to actually produce this like little kind of barrier around itself, so it can kind of convert ammonia and carbon dioxide by hydrolyzing some of those gastric fluids via that urease enzyme. Why is that urease important in terms of diagnosis? You can do a breath test, right? So it can help with diagnosis of it in and of itself. But basically, it's kind of buffering itself, and so it'll help to neutralize that acid, and then it can proliferate, right? And then cause its eventual ulceration. Looking at this, you're going to see that most non-NSAID-induced ulcers tend to be linked back to H. pylori. So you always want to keep that on your differential, especially if they're not saying that they had any sort of like obvious NSAID use associated with this, right? You're going to see that a lot of people, especially depending on geographics, can be infected with this. Some people are asymptomatic, but then those people that are not will develop those potentially, ulcers that can potentially perf. You can have, carcinogenic changes, things like that can occur there. I'm not going to focus so much on the sort of the methods of mucosal injury. Just know they will cause those ulcers over time. But I want to focus on the treatment here. So what are we going to use? So do they talk about using like a 3-drug and a 4-drug regimen, right? So remember, we're going to combination antibiotics. It's not frequently that we like to use combos of antibiotics to get one bug, right? Where did that come up last? Like TB, yeah, TB is a good example. What else? Maybe endocarditis, right? When we use gentamicin, you get that gram-positive synergy. So now when you think about like pneumonias, double covering. Or Pseudomonas we would double cover for, right? We'd use like a carbapenem and a fluoroquinolone or some combination like that. But this is another good example of that, where we're going to be using a couple different antibiotics. So typically we'll be sticking with something like clarithromycin, which is which category? It's a macrolide, right? Then we have amoxicillin, which is obviously, it's an immunopenicillin, more specifically, right? Metronidazole, which is kind of in class on its own. And then we have tetracycline, which is important, right? Because we just talked about what binds with tetracyclines. Your antacids might do that, right? So that could be a potential drug interaction there. We'll also usually put this in combination with either like a PPI or an H2 blocker. So for instance, you may see a combination. We have like ranitidine and bismuth put together. But usually you'll include bismuth subsalicylate, if you have BSS, that's what it stands for, included with the regimen. We've talked about Pepto-Bismol before, correct? Bismuth subsalicylate. Remember, there's issues. You don't want to give that obviously to young kids or post-viral because that still contains some salicylates, still some raised concern associated with that. But these are basically all the regimens you might be, or all the drugs you might be including in these patient regimens here. The reason why we include bismuth is usually because it helps to, one, provide some kind of gastroprotection. Usually it will coat the stomach and help out with that. It's also thought that it will stimulate some kind of endogenous prostaglandins that actually help to suppress H. pylori. So this is usually a frequent add-on to these regimens here. You see it comes in a couple different varieties that may include that. Citrate itself can be kind of a buffer if you ever see that included there. And sometimes we like to include, use these combination regimens. Why we use, or combination, products like this Helidac. Why would we try to compound them all together? Usually compliance, right? So again, with these 3-4 drug regimens, instead of popping 4 pills, instead you can just take, 1 or 2. That would obviously be more beneficial because some of these are requiring like, QID dosing, so it's pretty frequent they're going to be dosing themselves. So compliance is obviously going to be an issue. And again, treatment times are pretty long with this for the most part. So we used to use old 2-drug regimens, and those are not really recommended any longer, but typically you'll have either a 3 or 4 drug regimen. And you can see here, typically the 4-drug regimen is a little bit shorter treatment duration. With a 3-drug regimen, remember that if they fail that, this is typically where you then bump it up to a 4-drug regimen for the most part. And again, efficacy is going to be a little bit better with the 4-drug. So what are those regimens? Typically, with a common 3-drug regimen, you might start out with something like clarithromycin and amoxicillin, so you get 2 different classes of antibiotics there, plus a PPI, okay? Again, if that fails, then you could try switching up your antibiotics, so maybe using something like, tetracycline instead, or maybe using metronidazole or something. And then with a 4-drug regimen, that's typically going to be including the bismuth subsalicylate on there as well, right? So that's going to be kind of that 4th agent that you're adding on for that additional sort of suppression of the H. pylori, okay? You could potentially do resistance testing. I'm not sure how often they actually do that, but using something like, amoxicillin, metronidazole, and then omeprazole tends to have a little bit better evidence associated with that. So just some common regimens you might run into. Again, you're going to be choosing based off things like, tolerabilities and their allergies. So obviously they have a penicillin allergy that was true. You wouldn't want to use amoxicillin, so maybe switch it out to something else, like, metronidazole, for instance. Who might metronidazole not be good for? Heard it. Drinkers, yeah, alcoholics potentially, right? Why is that? Remember disulfiram flushing reactions you can get with that for sure. Who might clarithromycin not be a great option for? What sort of drug interactions come about from clarithromycin? CYP, okay. We could see QT prolongation. What else? CYP. If you had to guess which CYP, you're a betting person. 3A4, right? Is it inhibitor or inducer? Inhibitor, right? Good. Again, if I just ask you a random CYP question, and you'd had no idea, and you were just going to guess, for the majority of the time, you could just say 3A4 inhibitor, and for the majority of the time, you'd probably be correct. I'd rather you actually know the information, but if you just have to guess, far and away, that's the most common thing we've run into, right? Anyway, so looking at that, so again, watch out for 3A4 inhibition because clarithromycin is probably one of the worst ones. That and erythromycin can be pretty bad from that standpoint. So you could see those interactions there. But again, compliance is obviously going to be the biggest thing. Most people don't require antibiotic resistance testing right off the bat, but certainly if they have a failure of therapy, then you go back and can test for that for sure. If they do have a failure, that's when you're going to change up the regimen. Obviously, you choose 2 different antibiotics if possible, switch that out, and then include that bismuth there. And then try to shoot for the longer treatment duration, say 10 to 14 days or so for that.
What is the advantage of the bismuth again?
Again, you know, one, you get that nice kind of coating effect, which can help with healing, but they also think that this, having, basically you're stimulating some prostaglandins to actually help inhibit the H. pylori proliferation, I guess, yeah. Again, remember how bismuth can show up on an x-ray, right? You see the little punctate marks kind of throughout the GI tract, right? Any kind of metal like that can be radio opaque, right? So even if you see someone who's like taking iron tablets or something, you can see that definitely on the KUB. But so anyway, so who's going to be most at risk for NSAID-induced ulcers? Older individuals tend to be more at risk here if they have any history of GI bleed or peptic ulcer disease, obviously. Remember, concurrent corticosteroid use, right? So who might be on corticosteroids plus an NSAID? Like rheumatoid arthritis, right? We'll talk about that a little bit later. So again, that's not an unheard of combination, but just know that it's dangerous to mix those two together because you're going to get even worse prostaglandin inhibition. It's going to be more likely to see those ulcers develop there. Certainly using high dose or multiple NSAIDs. Have we talked about Toradol yet? We'll get there. We'll talk about Toradol and how that's pretty nasty for causing GI ulceration issues. There's actually only a certain duration of time you can be on that. Why do you think anticoagulant use would be a risk factor? Just a higher bleeding risk, right? So again, that you know, as that tissue gets more damaged, you're more likely to see bleeding occur because of that. And then any kind of chronic major organ impairments like cardiovascular disease, CHF, things like that can also increase your risk. So we know why this occurs, basically because if you recall, when we talk about cyclooxygenase, there's two varieties of it, right? So what are the two main varieties? It's COX-1 and there's COX-2, right? So what is the difference between the two? One is inducible, and one was the fancy term constitutive, right? Constitutive means what? It's always there, right? You're always expressing it. COX-2 being inducible means it gets ramped up in times of when it needs to be made, right? For if you stub your toe, sprain an ankle, whatever, COX-2 gets induced in this case. So COX-1 is going to be the constitutive form. That's the one that's primarily concerned with producing that nice protective barrier in the stomach. So most of our NSAIDs are selective or non-selective. In general, they are non-selective. They will affect both of those equally, such that when you do that, you inhibit that COX-1, you reduce that gastric protection, and thus the ulcer can occur there, right? And so again, when you're kind of comparing the two, you can kind of compare and contrast based on their presentation, one making you think NSAID versus H. pylori, but obviously the history is going to be the biggest clue giving us away. I don't know too many patients that would not be pretty forthright with their NSAID use. However, they may not associate that with the drugs they're taking as being an NSAID, right? So I can ask you, do you take an NSAID? You may say, no, I don't even know what that is. You got to follow up and say, well, do you take ibuprofen? Do you take aspirin? Do you take naproxen? You have to sometimes list out each and every one of them because, again, it's very common they'd be taking it themselves, but they may not even know what it is, right? Typically, if you're going to see like a GI bleed associated with NSAID, they tend to be more life-threatening than the H. pyloris are going to be for the most part. So again, as I mentioned, obviously the biggest thing, if they're on an NSAID and it's causing an ulcer, the first step in treatment is stop the NSAID, right? If that's not possible, right, it's for whatever reason, which is usually not a very good reason, but if you could not, again, dose reductions can help with this, or we'll talk about switching over to a COX-2 selective inhibitor or acetaminophen if possible. But we know acetaminophen is not going to be overall as effective as an NSAID for pain relief, but it is what it is, right? And again, as well, they could have a concurrent H. pylori infection that's just never been caught before. It could maybe was asymptomatic at the time. So if that's present, then obviously you would want to treat that as well. For the most part, though, stick with your PPIs for these because, again, they tend to be deeper ulcers. They tend to be more dangerous. So, again, go with the bigger guns there. Stick with your PPIs for the most part. Again, shorter treatment duration is also going to be beneficial when you're using those PPIs there. So, in these patients here, you want to consider using preventative therapy if they're going to go back on an NSAID. So we've talked about things like including like misoprostol, using COX-2 inhibitor, but certainly we may want to go ahead and if they have that history, just go ahead and give them a PPI along with their NSAID if they know they're going to be on it for a period of time there. And again, we know what kind of high-risk patients we have there, so certainly anticoagulants and corticosteroids, things like that, are always going to put them at bigger risk. So again, who is misoprostol not going to be good for? Yeah, pregnant women, we do not want to give that to them. What would it cause? It would induce contractions and labor too early, can cause an abortion to occur, right? So again, by giving this along with the NSAIDs, that can be somewhat protective, right? So again, you're replacing the prostaglandins your body's not producing already. And so we'll talk about pregnancy categories, but this one is a solid X. Have we talked about any other pregnancy category X drugs before?
Yes.
Like what?
Accutane.
Accutane's a good one. What else? Methotrexate's a very good one. What else? Valproic acid. I'm pretty sure that's an X. I'd have to double check, but I'm pretty sure it's an X. Anything else? How about our ACE inhibitors, our ARBs? Remember, those are solidly in that X category as well, right? So be really careful with that. We'll talk about OB-GYN stuff later when we get more into that, right? So X means there's absolutely no case for using that drug. The risk always outweighed the benefits there. And in fact, the fancy term you can use for that is an abortifacient. Means it can cause an abortion. So like methotrexate would be an abortifacient, right? So a little esoteric term there. Esoteric may also be an esoteric term for you as well, if you don't know that one. But typically you'll find that PPIs and misoprostol are pretty equal in terms of their efficacy here in preventing ulcers. Both of those will be better than your H2 blockers. Okay. In terms of maintenance therapy, again, it depends. You may not need maintenance therapy for every patient after that initial 4 to 8 week period there. Just depends. Obviously, the more high risk they are, if they're continuing NSAID use, and yeah, they probably need some sort of preventative therapy in those cases. Again, if they failed H. pylori eradication therapy, then certainly, yeah, you probably want to go ahead and continue some maintenance therapy in those cases as well. For the most part, you can always try dialing down your dose. So once that ulcer is kind of healed, patient's are asymptomatic, you've gone through the appropriate treatment course duration, then you try to dial down your dose, which is totally reasonable there. Again, patients don't need to be on this continuously. They can come off after a period of time. If they have to continue the NSAIDs, I would probably just continue either misoprostol or PPIs. PPIs are probably going to be a lot cheaper overall than misoprostol. So any questions on that? It's kind of quick, but we kind of covered a lot of that already when we talked about the GERD stuff. Getting into our antiemetics. So antiemetics are going to do what for us? Stop nausea and vomiting. Now again, why do we throw up? Why do we get nauseous? A lot of reasons, right? So it could be due to vestibular issues, right? So for instance, if you were to get on a cruise ship, right? So your eyes don't see anything moving, but certainly you're moving along in the ocean until you get your sea legs. That can cause some vestibular changes. I don't know if anyone's familiar with like using like VR headsets. Like that can certainly have seen some severe nausea and vomiting associated with that when your body is not feeling the same thing that your eyes are seeing. That can certainly lead to some dissociations there, some motion sickness. But certainly, what are some drug-induced causes for nausea, vomiting? Other than the fact that every single drug listed on their adverse reaction says nausea, vomiting, diarrhea, right? But more specifically, which ones are more likely to cause it? Chemotherapy is one of the biggest ones, right? So certainly chemotherapy is going to be a huge issue with causing that. And again, really any drug can cause that, right? Some patients even have like anticipatory nausea, vomiting we've talked about before. Post-operative nausea, vomiting is a big thing as well. So getting anesthetics, both kind of IV anesthetics, inhaled anesthetics, a lot of patients when they're coming out of that, they frequently will have nausea and will vomit, right? And what could be an issue with that when they're waking up from sedation? Aspiration is a big risk, right? So very frequently we'll just kind of pre-medicate a lot of those patients with, an antiemetic drug just to prevent that from occurring. So frequently with like ketamine, I've talked about ketamine before as being, we like to use it for conscious sedation. We'll talk about what that is later. But conscious sedation we would do for, if we had to like set a fracture or something. And we just knew that probably like half our patients, when they're waking up from ketamine, they always are going to throw up. And so because of that, we would go ahead and just pre-medicate pretty much everybody with a medication, just so that way we did not worry about them having that aspiration risk, right? Because that's oftentimes going to be worse and could lead to an admission rather than just sending them home once they're recovered, right? So our antiemetics, we're going to see there's a couple of different places we're going to be seeing them working. So certainly the vestibular apparatus is going to be playing a role here. We're going to see that the stomach itself has direct innervation that can lead to nausea and vomiting if it detects irritants or toxins and things like that. And then we'll talk about the chemoreceptor trigger zone, or the CTZ. You guys have heard of that before? It's kind of like the central place where nausea, vomiting is sort of managed there. So you can see here the vomiting center in the medulla. That's what's going to be kind of regulating most of that. And so we're going to see there's several different neurotransmitters that are going to be playing a role here. So 5-HT is playing a role. 5-HT is another name for what? Serotonin. So we see serotonin is going to be playing a role here. D2 is going to be referring to dopamine. Very good. So that's going to be important for some of our drugs and some of the side effects we'll see in a little bit. M stands for muscarinic, right? Because remember what was the E in dumbbells for our muscarinic cholinergic toxidrome. Emesis, right? So we're already seeing there's some ways we can kind of monkey around with this, maybe some receptors we can inhibit in order to prevent nausea and vomiting. So we already see some of this here. So starting out, we'll talk about our antimuscarinic and antihistaminic drugs here. So for instance, one we have is scopolamine, or transdermscope is a brand name for that one. This one is just a purely antimuscarinic drug. And this one's actually really good for motion sickness. So, we're pretty close to the coast and, a lot of cruise ships there. So you may be prescribing quite a bit of this if you stay in the area. But basically you just place it behind the ear. And the antimuscarinic action is going to help out with the vestibular apparatus when they get on the boat, such that they're not going to be having a whole lot of motion sickness associated with being at sea, right? Nice thing too is it's administered every 3 days. So if you're going on a quick 3-day cruise, slap that on maybe a couple hours before you get on the cruise ship, and you should be good to go from that standpoint. There are other ones. I'll have a list of this on the next slide, but you'll see some of the other antimuscarinic drugs that are pretty good for that. What do you think is going to be a big side effect from these antimuscarinic drugs? So we'll see anticholinergic symptoms potentially, right, which includes what? Blind as a bat, mad as a hatter. Remember, repetition is the cornerstone to adult learning, right? So this is why I repeat these things all the time. Granted, I see the same thing in my own 2-year-old now, and she's like watching, not that I let her watch TV. But she's so cute now, because now she sees there's this one song where they go through animal sounds, and she can't really enunciate them pretty well, but she can see she's actually getting the sounds right. So it's kind of cool when I see the same thing in you guys. It's just neat seeing people learn, right? That's why I do this. But okay, so the anticholinergic toxidrome, right? You know the symptoms that can come about from that. What about your mental status? Mad as a hatter, but before you get to that point, what's kind of the most common thing? Sedation, right? So you're going to see sedation associated with a lot of this, which in fact may be okay, because we will sometimes give transdermscope to some of our patients before they go to surgery, and it kind of produces this kind of twilight amnesia. It's kind of this term we use, so that way before you go to surgery, you may not remember a whole lot of the details before you actually go under. It can be useful. But again, if you're on the cruise ship and you like to get out and go swimming or do whatever you want to do, if you're in bed because you're too sleepy, that's not great, right? So again, you gotta have to kind of balance that. Whenever you're using these transdermscopes, you have to really make sure the patients are going to wash their hands afterwards, because otherwise it can present a presentation like this. So what do you think happened to this particular person? They put on the patch. Which eye did she rub? Right, remember, it causes anticholinergic effects cause miosis or mydriasis? Mydriasis, so you can tell that her left eye was the one that she ended up affecting, right? So she accidentally rubbed it, and then she sees this. If you were to see this come walking through the ER, you'd probably think they had some kind of stroke or something like that is going on, right? You'd be very concerned about that patient getting into the CT scanner, and they'd be like, "What's going on? That's no big deal. This eye's a little sensitive," But that's kind of an interesting thing you can see with that particular drug. But yeah, dry mouth, blurred vision, urinary retention, constipation, right? Maybe okay, because again, if you're on a cruise ship and you're eating all those buffets and everything, maybe a good thing, maybe a bad thing, who knows? But anyway, here's some other ones. These are oral agents you'll see used pretty commonly. There's several of them. Most of them are over the counter, so things like dimenhydrinate, meclizine, hydroxyzine. That's actually more of a prescription-based product. Diphenhydramine is the most common one. Most people are familiar with Benadryl. Glycopyrrolate. Actually, this is another antimuscarinic drug we use pretty commonly for kids that have chronic drooling issues. We use it for that the drying effects you can see with that, right? Because it's going to dry out the salivary glands. So that can be a good one. Hyoscyamin or Levsin. This is actually a good one. It's more of like an antispasmodic agent. So because again, blocking cholinergic receptors in the GI tract is going to speed it up or slow it down. Slows it down, right? It decreases peristalsis. So you're having a lot of abdominal cramping. Something like hyoscyamin or Levsin is actually pretty good for helping to decrease some of that spasming that's seen there. But again, sedation is the biggest side effect you're going to see in those antimuscarinic effects, which you obviously already know because you were able to parrot it back to me, no problem, right? Up next, we have our anti-serotonergic drugs, and so these are going to be 5-HT3 receptor antagonists, right? Now, when we were talking about migraines, which serotonin receptors were we affecting? Oh boy, you might want to know this for the exam. Remember, those are 1D and 1B receptor agonists, right? Causes the constriction of those cerebral blood vessels. Here we have 5-HT3, so serotonin just has a ton of different subtypes of receptors. This 5-HT3 we're focusing on. And these are going to include ondansetron, dolasetron, and granisetron. Far and away the most common one you're going to run into is ondansetron. I've done Kytril a couple of times for some kids getting chemotherapy, but 99 times out of 100 it's going to be Zofran for just about everybody there. I mean, this stuff flows like water in the ER. So we basically, we have a nursing protocol in our ER where basically things like Tylenol, ibuprofen, really the kind of the common stuff. That way the nurses can go ahead and just say, okay, kid's got a fever, we're going to give them Tylenol, right? Helps expedite kids getting their treatment a little bit faster. We end up putting Zofran on that list, oral Zofran, because again, a lot of kids are coming in nauseous. You don't have to wait for the provider to go see them in order to put the order in. The nurse can just take care of it. Boom, kids got it. Great. These are really pretty safe drugs for the most part. There's a couple caveats with that, but for the most part, that's one of the big benefits of it when they came out on the market is they had almost no side effects compared to some of the other drugs we were talking about. There's no sedation with these, no antimuscarinic effects. It's very clean in terms of its mechanism of action, in terms of its side effect profile there. The one thing I will note is this QT prolongation. You do want to be careful with that. With anyone who has maybe a history of baseline prolonged QT, or anyone who's on multiple QT prolonging drugs, right? So if they were on, say, azithromycin and they were taking, I don't know, fluconazole or something. All right, that combination of drugs together can prolong that QT and can lead to torsades, right? And which you would treat that with magnesium, absolutely good. So again, very good. And in fact, this is kind of a revelation because back before this, all they had for chemotherapy-induced nausea vomiting for the most part was really Reglan. We'll talk about some of the drawbacks of using Reglan in just a moment here. But very good set of drugs. We'd probably be prescribing it all the time. Handy number to know for Zofran. If you had to know one number for Zofran, 4 milligrams is probably the most common dose you're going to be administering to adult patients, right? So 4 milligrams of oral IV. The nice thing as well with oral dosage forms of Zofran is it comes as an ODT. Remember what that stands for? Oral dissolving tablet, right? So you can just basically put it in the cheek and it'll dissolve and will absorb. Great, because if you're nauseous, you don't want to have to swallow anything, right? Okay, so then next up we have our anti-dopaminergic drugs. So these are going to be blocking D2 receptors, okay? So the one far and away you're going to use most commonly is going to be Reglan or metoclopramide, okay? And then we have the phenothiazines. Phenothiazines are going to come up in the behavioral health section a little bit later on. Have you talked about antipsychotics with Dr. Austin yet? We'll get into that in a lot of detail, but these are actually all from the same category, essentially. So we've talked about prochlorperazine before, back when we talked about migraines. That's another common one we'll use for nausea, vomiting associated with migraines. We have things like promethazine. I mentioned that one at least before. We have things like haloperidol, right? These are antipsychotic drugs that work by blocking D2 receptors. And we'll talk about why that is later, but this also helps work as an antiemetic drug by blocking these D2 receptors in the chemoreceptor trigger zone. That will also help decrease that nausea and vomiting, okay? So basically, things you're going to see with these drugs is they frequently also have anticholinergic properties, which is also why they're good for nausea and vomiting. So you're also going to see side effects related to that. But in particular, the big issue we worry about with using especially like really high doses of things like Reglan is that when you block D2 receptors, you can induce movement issues. Does that make sense? Why does that make sense? Because remember, what disease state is that like? Parkinson's, absolutely. So you can cause a drug-induced Parkinson-like syndrome by giving D2 antagonists. Okay? So this is a chemical means of inducing similar effects. So you can get the bradykinesia, you can get the akathisia, you can see with that, you can get the, most oftentimes you get dystonic reactions, right, where the muscles are going to contract up and they really have no control over that, right? And it's that disbalance between dopamine and acetylcholine. So again, you don't see it very commonly with like typical like single-time doses. One-time dose is not a big deal, but the bigger doses, like if you're using this for like chemotherapy, big deal. For long-term use, you can also induce what they call tardive dyskinesia, which is kind of a long-term effect we'll talk much more about in the behavioral health section later on. So just kind of keep that in the back of your mind. Other things you can see is increase in prolactin levels. That's kind of another side effect of blocking dopamine. If you decrease dopamine effects, you can actually increase prolactin. And normally what does prolactin do? Helps with lactation, right? So what effect might that have, say, on women who, say, want to become pregnant? They will not ovulate typically if they have high prolactin levels, mainly because if you're trying to nurse an infant and feed that, does your body necessarily want to start getting the next one ready to go? No, you don't want to divvy up your resources too much there, right? So it makes sense your body would try to shut that ovulation down if you have a lot of prolactin. So oftentimes you can find that women may, especially like PCOS and things like that, they have hyperprolactinemia, and that can end up leading to anovulation because of that. So this is actually something that can induce that from a drug standpoint. Okay, and in fact, one of the things you can actually do to decrease prolactin levels, you have a dopamine agonist. So you can give like bromocriptine, or you can give cabergoline or something like that to actually cause prolactin levels to go down. That can actually induce ovulation in some cases. So, and then the worst side effect you worry about, and this is rare but could occur, it's called neuroleptic malignant syndrome. It looks a lot like serotonin syndrome, but we'll talk more about that in the behavioral health section. So just keep in mind that these can cause neuroleptic malignant syndrome. We'll talk about why that is, what it is later on. Okay. Any questions on that?
For the smoking patch, since a lot of people that go on cruises are drinking too, do you have any issues with like increased sedation?
What do you think? Yeah, that could be a risk. Again, you may tell them, hey, take it easy, see how it's going to affect you. Fortunately, with alcohol being so prohibitively expensive on those things too, maybe that kind of helps control their intake a little bit. Unless you're smuggling it in somehow.
Usually it's all included.
Or if it's all included, you pay for that, yeah. So, excuse me, I didn't realize you had high rollers in here. Anyway, no, it's fine. We would sneak it in. Actually, you know, it's funny. So I dabble in home brewing of various libations, mostly wines. But it was interesting when we went to a homebrew store. We were first kind of like getting into the idea of it, and there's these people there that were basically they were like emptying out these bottles of wine, and then they were like filling them back up with vodka, and they're using the corker at the store to cork it back down. And I was like, that is ingenious. Like my. Then they kind of wasted all the wine, so I don't know, it wasn't very good. But anyway, so there's a lot of ways to get booze onto cruise ships. But you should be careful if you're using scopolamine plus any of that booze, because you could see synergistic effects there, right? Knock you back in the bed. Anyway, so next off we'll talk about the cannabinoids. So cannabinoids, we'll talk more about this in the kind of ortho section. We'll talk about medical marijuana there, but there are two primary cannabinoid receptors that we have in the body is CB1 and CB2. And have you talked about much with medical marijuana, maybe with Professor Kaplan yet? A little bit. That's kind of like his jam, right? Professionally, I have no idea about. I claim to make no knowledge about any other sort of use there, but professionally, he was facilitating people getting their green card, right? Anywho, looking at this, we do have synthetic forms though, right? So basically we have synthetic forms of THC, or delta-9 tetrahydrocannabinol. That is the main psychoactive component of marijuana. We have synthetic forms of this. We have dronabinol, which is otherwise known as Marinol as a brand name, and then we have nabilone or Sesamet. These are actually good for chemotherapy-induced nausea and vomiting. They do have good antiemetic actions there, and so will help out with that. Now, does that mean that this works better or worse than actual medical marijuana? I don't know. I haven't done the study. No one else has either, right? Because federally speaking, marijuana is Schedule I substance, right? So it's very difficult to do any kind of studies with it, right? So we don't know which one works better or not. Some people respond really well to marijuana. Some people do just fine with using Marinol, right? So some people have a hard time because I mean we'll get this to kids receiving chemotherapy all the time. If you had to say, hey, little Johnny, would you like some pot? Moms might not like that so much, right? So there's still a lot of social stigma around this, but this works quite well, right? So we actually have a lot of kids who are on this. The other nice benefit though is what does typically marijuana do to your appetite? Stimulates it, right? So this is an appetite stimulant, which is also really good because what happens when you're receiving chemotherapy? You don't want to eat, right? You feel awful, you feel sick all the time, and so they end up losing a lot of weight, which is not great. So we end up putting them on something like this, and that will stimulate appetite. It will help to decrease nausea, vomiting. It's not as strong as something like, say a Zofran or something, but it's a nice adjuvant drug, right? It's nice to help kind of stimulate that as well. What are, I think, the side effects of THC? A little bit of sedation. How's your coordination? Pretty good? You can take a hit, right? So maybe a little bit incoordinated. How about memory? Nice.
You said it.
I did. How about memory? Forgot where I was. Some short-term. Some short-term memory effects, right? Some people just do not do very well with THC. Some people get like paranoid, and they can, I mean, it can be very severe. You see this a little bit less with these. I've never run into anyone with really too many side effects associated with this. It's easier to dose this for sure than something like the actual plant-based marijuana, because again, how do you know how much THC is really in there? It's difficult to tell. So this is a little bit more stable in terms of the dosing. It's FDA approved, you know, so there's that. We'll talk more about medical marijuana a little bit later on with some of that. However, do cannabinoids always decrease nausea and vomiting? No, I remember we talked about this a little bit yesterday in one of the groups in lab. What happens if you're a really, no pun intended, chronic user? Yep. That one didn't get any laughs? Wow, tough crowd. Anyway, so if you're a chronic user, heavy user of marijuana, what can develop? Cannabinoid hyperemesis syndrome, right? And so how do you diagnose that if they didn't want to tell you about their
Hot water bath.
Yeah, I remember the hot showers are the only thing that makes it feel better, right? So, because again, you can test anyone, they may be positive for THC, but they may not necessarily have nausea vomiting induced by that. Because again, naturally it's an antiemetic. But yeah, if you had that history, they take hot showers, and that's the only thing that makes it better, that's usually a pretty good sign of that. How do you treat it? Smoking cessation, right? Or cessation of the marijuana, right? Okay, up next we have a couple of substance P antagonists, and so substance P, which normally helps to facilitate, sensitization of nociceptive fibers, pain fibers, right? You guys know what nociception, like nociceptive fibers, they transmit pain signals. Normally, substance P, and we'll talk about this with like capsaicin a little bit later on, how that can affect pain, but it also can induce nausea, vomiting, and so we actually have some substance P antagonists that blocks that effects there. So we have like aprepitant, and these are mainly relegated towards treatment of chemotherapy-induced nausea, vomiting. So remember we talked about the alkylating agents being sort of the worst. Cisplatin being one of the worst of the worst, right? So we would give aprepitant, and it helps not only with sort of the initial phase of vomiting that occurs with something like cisplatin, but there's also sort of a delayed phase, usually up to 72 hours after. And so we would start this along with the other drugs of the regimen, and then continue that up for maybe about 72 hours or so to prevent that nausea and vomiting. Remember, like with some of these drugs, drug regimen for chemotherapy, you can find them on, they may have orders for Benadryl, lorazepam, which is a benzo we talked about briefly, right? We talked about seizure meds. We use that as an anxiolytic to help with that preparatory or anticipatory nausea, vomiting. They'll have Zofran, they'll have aprepitant, maybe even Decadron on there. Decadron is what drug? Or what type of drug? It's dexamethasone, which is a steroid, right? So again, you can sometimes use that to treat leukemias, but it also can help as an antiemetic as well. So they can be 4 or 5 drugs just for the nausea and vomiting. It can be so severe. So don't be shocked when you see patients are on multiple antiemetics depending on the situation there, right? This one does interact with CYP3A4, so you may want to look for dosage adjustments of anything that affects or it will be affected by, so be careful with that. And it does induce CYP2C9, so be cautious. As I mentioned, corticosteroids can be useful for chemo-induced nausea, vomiting. It's probably the most common thing you'd see that. And so prednisone, dexamethasone, any of them are totally fine from that standpoint there. And then as I mentioned, benzos are going to be good as an anxiolytic, so not necessarily, they don't have sort of innate antiemetic actions, but if you have that anticipatory, like, oh man, I remember last time I got that drug, I was throwing up like crazy, this can help out with that, right? Kind of chill the patient out a little bit. So lorazepam, alprazolam, any benzo is going to be fine from that standpoint. How do you choose an antiemetic? Frequently, it's going to be based off of the specific patient situation. So is it because they have a migraine? Is it because they are pregnant? Is it because they are receiving chemotherapy? There's a million different reasons for someone to be nauseous, and that will help dictate kind of what drug you're going to be using for them, right? So typically, if they can't tolerate oral, you can use something like IV routes. You can use IM, PR, any of those are going to be totally fine, depending on the agent. Typically, promethazine is probably the most common rectal one you'll see as a suppository. Most other stuff you can just give IV. No problem there. Typically for motion sickness, because that's more mediated through the vestibular apparatus, antimuscarinics tend to do better there. So you want to use something like a dimenhydrinate, you want to use something like a transdermal scope. Those are going to be a little bit better from that standpoint. And then in general purpose, things like Zofran are kind of good for general purpose nausea, vomiting. You really can't go wrong with a little bit of Zofran for most people, right? Okay. Let's do a 10-minute break. We'll come back and then continue on talking about some prokinetics. Any questions from the first half? This is a fun comment. My dad literally snuck scotch onto a cruise ship by putting it in a huge Listerine bottle and shrink wrapping plastic on top as a seal with a hairdryer. Help. Sounds like your dad's got all the help he needs. We found these, I don't remember what they call them, like booze bags or something like that, but they're like plastic containers, and basically like when they x-ray them, it doesn't like show up as anything, so you have these like little plastic sacks in your luggage.
Where do you get those?
I think Amazon, I think. Where do you get everything? Amazon, yeah, 100%. Any questions from the first half? Was it a gaming podcast? I don't know. Who's to say? Okay, so let us continue on. Any questions at all? Antiemetics. Okay, so getting into prokinetics, we see that Reglan actually fits on this category too. And I think Professor Q was mentioning this yesterday in a lot of the labs. If you have someone who has, say, for instance, like diabetic gastroparesis, this is a good agent to use for those patients. So, anything that helps stimulate passage of that food from the stomach on to the rest of the GI tract can be helpful here, and Reglan's a really good one for that. There's a couple other agents we'll have here as well, but basically it helps to stimulate gastric emptying, will decrease some of the lower esophageal sphincter tone, things like that to kind of move things along. Also good as an antiemetic, so you get kind of a dual action there, you'll see. Again, be aware of the same side effects you'd see it as an antiemetic, so decreased dopamine action, increased prolactin, et cetera, right? Now erythromycin is a little bit different, right? Because erythromycin is what kind of drug? It's a macrolide. You're like, why would you use an antibiotic for motility? And actually what happens is that it works on these little motilin receptors you have in your GI tract to stimulate prokinetic actions as well. And so this is another very common one because we don't want to, I see this used more often in children than I do metoclopramide, mainly because you lack a lot of those dopamine actions there. So typically the dosing is a little lower, but if you see someone who's on erythromycin just daily with no stop time on it, that's usually going to be someone who's taking it for prokinetic purposes there. So normally you'd expect an antibiotic 7, 10, 14 days. This is just going to be continuously there, right? Obviously, in terms of side effects, you're going to see with that a lot of cramps. You can actually see impaired motilities in terms of like a withdrawal sort of effect there, so you want to be careful from that standpoint. But used very frequently in children who have motility issues, gastric paresis, things like that. Very, very handy drug. Okay, so moving on to the laxatives. Let's see, so common causes of constipation. What are some drugs that can cause constipation? Opioids, absolutely. Opioids are a huge one. What else? Anticholinergics, absolutely. What else? Antacids, right? Which one specifically? Calcium, aluminum, right? What else? Aluminium, if you're of the British persuasion. What else? If I have patients hypertension, calcium channel blockers, absolutely. Anything else? Iron, yes, absolutely. Iron will do that, right? Especially when you think about, women having to take prenatal vitamins have iron in them, and they get pregnant, they're still taking their prenatal vitamins, and they're getting constipated from the pregnancy anyway. It's the whole thing, right? It's not great. Right, so a lot of drug-induced causes for constipation, and again, very frequently, you have patients complaining of that. Look for the underlying cause, because if you can rectify that, no pun intended, you can hopefully not add on a whole nother drug. That one hit a little better. So, Cam's not impressed. Okay.
It was good.
Yeah. Anyway, and actually this can be a big problem, especially in pediatrics too, because if they have sort of a bad experience, they tend to develop this holding that occurs there. And actually I was talking about the article I think a couple of days ago, but they were saying that if you try to potty train your kids too soon, they're actually saying that it causes them to, start working on those muscles to hold on to their stool and their urine. And actually that causes the hypertrophy. So actually they have holding issues later on in life. And we'll see that there's a ton of kids that have constipation. It's a very frequent cause for abdominal pain coming into the ER. Almost every single kid coming through the door with abdominal pain in the ER, constipation. 9 times out of 10, right? You just take a KUB, kids are just FOS, right? Full of stool. Anyway, so our goals here: relieve the symptoms, obviously, pain, cramping, etc. Try to get normal bowel habits. So, depending on the age of the patient, that can differ. Most adults, typically once, twice a day. Increase quality of life, obviously, because if you can't stool, your quality of life's not that great, right? We would have, my wife, when she did her second year of residency and pain management specifically, she was doing it was at the VA, and so of course you have all these older vets, and all of them have chronic pain issues, and a ton of them are on opioids, right? And so you would not believe how many patients you just couldn't get their pain meds under control. Like, just no matter what you did, they're still uncomfortable, they're still in pain. All of a sudden, if you could fix their bowel regimen and they could start stooling normally, all of a sudden their pain scales went down, vital signs improved, they felt a million times better. So never underestimate the value of a good poop, okay? I think I'm joking, but I'm serious, okay? So anyway, so what are the mechanisms we can use to increase stooling? Well, we can try doing things like increasing motility. So, certainly something like a Reglan or erythromycin can help to stimulate that. But we'll look at some other ways we can directly stimulate that as well. Also, when you think about the stools that are difficult to pass, they're typically a little dehydrated. They can be quite large. It can be very difficult to pass. Or you guys seen that Tanner, what's it called? The Bristol, the Bristol stool chart, right? So you've seen all of those. When you get those like little rabbit pellets, those are not healthy, good stools, right? It's typically signs of like dehydration, not enough fiber in your diet. Honestly, when you become a parent, you'll become much more acutely aware of stooling habits of other individuals, and never in your life will you be as excited as when the baby finally went poo. Yes. Because when you transition from like breastfeeding over to like solid foods, it's a nightmare. It is awful because all of a sudden their biome is just thrown completely in upheaval, and they get very cranky when they can't poop. So when they do, I frequently get a text from my wife saying, "Got it for the day." A little emoji. I say, yes, okay. No cranky kids. All right, anyway. So other things you can do, right, when you have those little dehydrated hard stools, you can try to increase the water content. It's going to make them a little bit easier to pass. We'll talk about emollients, stool softeners that can help out with that. And anything that's going to be decreasing the water and salt reabsorption within the colon, that's going to stimulate a lot more volume there. And as you stretch out those receptors, it's going to stimulate defecation. So it's going to be a really kind of quick, easy way to stimulate defecation to occur. Okay. So why do we give laxatives? At what times would you want to do it? So certainly if they're complaining of belly pain, you take a KUB and you see that they're full of stool, absolutely. But some other things we might do it. So for instance, if you're getting them ready for bowel surgery, or say they're getting the colonoscopy, anything like that, you want to clean everything out. This is a good indication to use some of these laxatives here, right? Sometimes we'll do it to actually increase excretion of certain poisons or toxins. So for instance, if I have a patient who, say, took a lithium overdose, we'll talk about lithium and its use for bipolar disorder later, but it's something that doesn't bind to charcoal, and we don't want it to get absorbed into the system. So if we can't get it with anything orally, we just try to flush it all the way out. And we can use certain regimens to try to increase that expulsion of the lithium and thereby decrease overall body burden that it gets absorbed, right? So there's ways to do that. We can do post-operative stimulation, because again, when you're going under for surgery, frequently you get a lot of opioids, which causes constipation, and you worry about post-operative ileus. So frequently, post-operative orders will include things like laxatives, because you want to make sure the patient is going to be stooling normally after surgery. So a lot of other common causes for this, just temporary relief of constipation, certainly got regimens for that. And so which ones we use, how we use them, we'll talk about how that differs. Now typically this is going to be contraindicated in underlying bowel disease. So if you have like a patient with like uncontrolled Crohn's and things like that, you don't want to further irritate the bowels. So typically those would be, these laxatives would be contraindicated for those patients. So generally, what do you think side effects are going to be for laxatives? Diarrhea would make sense, right? So again, you can always tip the balance too far one way or the other, so you can actually cause diarrhea in a lot of these patients. But again, they're stimulating peristalsis, so you're going to see abdominal cramping for sure. Nausea, vomiting can occur depending on what's going on with the patient there. And then chronically, you typically don't want to use chronic laxatives as best you can, because typically what happens, and this is more often than not, you're going to see typically with a type called stimulant laxatives, which we'll talk about in a few moments here. But with any muscle that you're not using, it tends to atrophy, right? And so you can actually find that if you're giving substances that directly stimulate defecation rather than having the patient actually do it themselves with their own muscles, you'll find that you can damage the nerve tissue after a while. It can damage the muscles, and that can actually lead to where they basically are just like dependent on those laxatives to be around to defecate. And not only that, we can see issues of malabsorption eventually, dehydration, the microbiome can be disrupted, all kinds of problems. So typically short courses of this stuff is what we're looking for the most part. So 3 categories we're going to talk about. So we're going to have those that soften the feces, about 1 to 3 days or so. So these are going to be a little bit shorter, or a little bit taking longer to work. So we're talking about bulk forming agents. We'll talk about emollients. When I say emollient, what does that mean? Because you use emollients on our faces all the time, right? Use that same stuff for feces. It's usually something that increases the water content, it moisturizes. This is going to be a stool softener, right? It's going to emollient, it's going to make it easier to pass, make it a little bit more, lubricates it, it's going to be easier to pass it, right? We'll talk about osmotic agents as well. Again, increasing the amount of osmotically active particles in the GI tract is going to draw what into the colon? Water, and that's going to stimulate defecation for sure. We'll look at things that will produce maybe soft or semi-fluid stool, maybe in 6 to 12 hours. We'll look at some stimulant laxatives that work there. And then there's some ways that we can actually cause just an entire watery evacuation within 1 to 6 hours. So this is where we talk about our osmotic laxatives. We'll see they kind of fit into either category there, depending on the dosing we're giving. Talk about enemas and then bowel cleanouts. Okay. So looking at our bulk forming non-digestible dietary fiber. Now as the U.S. culture, we typically have pretty low fiber diets for the most part, which is why we have so many kids that are constipated and adults for that matter. But things like psyllium husk, things like your metamucils, things like your methylcellulose, again, those are handy because they are non-digestible fibers. They will help to lubricate the GI tract, make things a little bit easier to pass there. Typically, how do they come in terms of dosage forms? Is familiar? Typically, it comes as powders, right? They're pretty kind of grainy kind of powders. So in terms of palatability, what do you think about that? They're pretty gross. Yeah, they're pretty nasty to choke down. A lot of patients cannot tolerate it, right? So in some cases, you may find some tablets that are available, but the gritty powder is kind of what you're stuck with in a lot of cases there. You can see they increase the bulk of the stools, they increase the water content, just making them a little bit easier to pass in those ways there. These are more like kind of everyday kind of easy things you can incorporate into a patient's regimen that will help them stool normally, right? So more chronic kind of medications. Biggest thing to watch out for though is mixing these with other medications because they will tend to bind them. So you either want to give the other medications maybe 30 minutes, an hour before the fiber supplement, or you would want to do it maybe 3 or 4 hours after the fiber supplement, right? That way you prevent them from absorbing one another. Getting into the stool softeners, you have a couple of different options here. So we have things like mineral oil, we have things like glycerin, which is probably one of the more common ones we run into, and then docusate or colace is another very common one we'll see there. Basically, they get incorporated into the stool itself. They increase that water content and again just lubricate it and make it a little bit easier to pass. That way, maybe if you have some patients with cardiovascular history, you don't want them to Valsalva too hard. It just makes it easier for that to pass. Little kids may not have to hold quite as hard. Those are all going to be very useful there. You'll see some of these either used orally or sometimes they may actually be administered rectally. So for instance, like glycerin suppositories for infants is probably the most common means of relieving constipation for them. Docusate comes usually as like a tablet they can take. So again, there's different dosage forms that are available depending on the case there. Next we have stimulants or irritants. We used to use like castor oil. It's kind of like an old like home kind of remedy there. Don't see this quite as often anymore, but certainly things like senna and then bisacodyl, probably the more common stimulant laxatives you're going to find there. Basically, they directly stimulate the colon to increase motility. These are the ones you want to be really careful to use as short term as possible because the patient will get dependent on this, right? They'll kind of get used to that effect of being around all the time, and thus when you remove it, they basically can't stimulate peristalsis on their own unless they can't defecate. So you get kind of like a rebound sort of constipation that occurs there. Okay, so short time frame if possible. And these you'll frequently see in combination with something like a docusate. So you may see bisacodyl or senna plus docusate, so that way you get a stimulant plus a stool softener together. That's kind of the most common combination there. When we talk about opioids more specifically, I'll talk about bowel regimens for them. And typically everyone who's going to be on opioids chronically, they need to be on a mush and push regimen. This is what I'm referring to, right? So the push is a stimulant laxative, the mush is a stool softener. Make sense? Hopefully. See all the grossed out faces, but it is what it is. Just wait till we talk about the OB-GYN section. That gets a whole new level of awkward for me, so just wait. Next up we have the osmotic agents. Again, these are working to increase the amount of osmotically active particles to draw more water in. That does help hydrate the stool, but also directly stimulates motility in and of itself. A lot of different options here. Some of them are available orally. Some of these are going to be available as enemas. Again, enemas are directly instilling all that volume directly into the rectum. Again, stimulating that kind of like, hey, we got to go to the bathroom right now. If you need to get someone to poop right now, an enema is a good way to do that with usually with one of these osmotic agents here. So things like mag sulfate can do this. Milk of magnesia is probably the more common magnesium salt that we'll use in that case there. Remember I talked about it being called the green rocket? Because again, when you drink it, you get that effect pretty quick and you gotta go to the bathroom like a rocket. So anyways, milk of magnesia. Things like mannitol can be used. Probably the most common enema that we'll use for patients is going to be sodium phosphate based enema. So if you hear a fleet enema, that's what that's referring to, is sodium phosphate. Now they seem pretty benign in terms of their actions, but actually people have died before from using sodium phosphate enemas. Actually, they can develop hyperphosphatemia, and this is usually due to either too much being used or it is due to too frequent use. And it's not necessarily like a healthy adult is going to be able to really have a problem with all that phosphate, but it's the extremes of age. So we've had like infants that have died from this, and then very old patients, typically with like end-stage renal disease, that have actually died as well. And the FDA put out a big warning about it. So be careful using your fleets enemas sort of with reckless abandon, because you may find that some people cannot handle that extra phosphate load, right? So typically extremes of age. One thing to remember though, if you ever have a neutropenic patient, you don't want to administer anything rectally to them. Why is that? Right, you worry about those little micro tears in the tissue. Remember that tissue is very friable, it's kind of brittle. You worry about translocation of colonic bacteria and then infection, right? So again, neutropenic patients, never give them anything rectally there. Right, so these are kind of your quick go-to. We'd have some providers, you know, it's interesting seeing kind of the prescribing habits of different individuals. I frequently see for like newer school doctors, people are just kind of fresh out of like residency or fellowship, you know, they typically are a little bit nicer to patients. They'll say, okay, we'll may give you like some Miralax, and I'll talk about Miralax in a minute, you know, or I'm sorry, the polyethylene glycol is right there on the slide. That's typically going to be, you know, kind of given orally. Not going to be too quick acting if you're given relatively low doses. They'll give them that and say, okay, we'll see if you have a bowel movement. I see the old school docs for some of our kids, like teenagers even, they're like, no, you're getting the enema. We're getting you emptied out right now. And of course, you know, obviously patients may not be as compliant with that, or they may not really prefer it because, again, it's kind of embarrassing and they don't have to do that. But it works very effectively. Now you notice here there's kind of two brand names there for polyethylene glycol. There's Miralax and there's Go Lightly. Miralax is typically going to be like your everyday sort of like maintenance of stooling kind of chronic medication. Anyone ever seen Go Lightly before? So this is what you use for like bowel preps. This is what you use when you're getting ready for surgery, or if you want to do like an endoscopy or more like a colonoscopy, I should say. This is what's going to like really clean out the patients. And so it basically comes in a big 4-liter container, plastic jug, and it's got this like powder in it. And the reason why it's called Go Lightly, L-Y-T-E, what do you think that is? Electrolytes, right? So the nice thing about that is it doesn't really cause any electrolyte shifts, right? So even though you're giving a high osmotic load, you don't see any issues with their sodium levels. You wouldn't see any hyperphosphatemia because it doesn't have a whole lot of sodium phosphate in it. And so it is balanced in that way. And so it basically will cause, and again, it's like 4 liters you're drinking all at one time. And the idea is to flush out everything from the GI tract in order to have a clear view if you're doing a colonoscopy or something. It's a good question. Yeah. So when people, so imagine what do you think Go Lightly tastes like if it's all those electrolytes? Tastes like salt, right? So some people say it tastes like warm sweat. Yes. I'm glad I've never had to drink it, but 40's coming, right? So yeah. So it sounds like it's pretty gross, but in some cases you can maybe mix it with something like a Gatorade, but you have to be really careful about which flavor you do. So for instance, you probably don't want to drink it with like a red kind of Gatorade, because then if your GI doc is like going through doing your colonoscopy, what does that look like? Blood, right? So that would not be great. Typically, no, we just have them drink it. So, and this is also what we would do for instance, that lithium overdose I mentioned. This is what we would do for those patients as well. So basically, in some cases, we'd be doing up to like 2 liters an hour. So imagine drinking 2 liters of anything an hour. That's a lot, right? And imagine if it's something that's going to be making you go to the bathroom. So you need to be on the commode, ready to go, because this stuff is going to clean you out, right? So, yes, sir.
Is it more intense than max citrate?
I would say it's probably more intense, because max citrate, you're just using relief from constipation. This is meant to evacuate. I use evacuation as the term. You don't use that lightly. Okay. That's what they say. So there's nothing light about how you're going when you take Go Lightly. Okay, so be aware of that. Make sure the patient's not like, I'm going to go to Walmart and take my Go Lightly with me. It's like, no. You need to be in the restroom. Anyway, and in fact, when we're using it for tox purposes, we actually say our endpoint And frequently, we have like if you have like a suicidal patient, they're not going to want to necessarily be compliant with this. We actually end up having to put an NG tube down a lot of times just to get the rates that we're looking for to clear them out. And we look for clear rectal effluent. That way we make sure to get everything out of the GI tract. They're not going to absorb any more drug. And sometimes what we'll do, we'll have a trick we call go darkly, where we actually give a dose of activated charcoal first to bind up any other medications that might be there, and then follow it up with the go lightly. So we can actually use that as like a tracer. So once they start pooping black, then we know, okay, yeah, the charcoal's coming through. Everything should be kind of moving through at that point. So we don't do it too frequently because it's kind of a pain in the rear, as it were. So again, pretty common like for bowel clean outs, things like that. We have a lot of kids get admitted from the ER for constipation just for their bowel regimen. And I'd be so embarrassed if my kid got admitted just to go poo, right? So that's why I make sure they get lots of fiber and do the best I can. Anyway, moving on. So again, when you're deciding kind of what to use, it's always easiest if you can try to increase water intake, increase fiber intake, if it's appropriate for the patient there. Typically, you can add on kind of easy stuff first, like an emollient. You can try using like an osmotic laxative, something like a nice lower dose Miralax. That's been easier now that it went over the counter. It was prescription, for a long time there. Maybe try out 2 to 4 weeks or so. If they're not really having any bowel movements for 2 days or so, that's where you can consider using a very short course stimulant, right? So again, this is more for kind of as needed, you need to go right now kind of thing. It's been a couple of days. We will talk about using certain opioid receptor antagonists if the patient's on opioids. We'll talk about that in the ortho section. Basically, we have some agents that work specifically on opioid receptors in the GI tract, and they'll actually kind of wake the bowels up for patients like post-op and things like that. And then, as I mentioned, osmotic enemas, typically those are for acute evacuation. So if like you're in the ER and you just want to clean them out, that's typically where you're going to be using your enemas for the most part. Okay. Now, we have a couple of antidiarrheal agents we'll use as well. These actually help to decrease GI motility, and actually the best way we can do that is by stimulating the opioid receptors in the GI tract, because we know it causes constipation, so we can do the same thing for these guys here. And basically, these are agents that themselves will act on opioid receptors, but they can't cross that blood-brain barrier. Is that where I was talking about loperamide before, that interaction with cimetidine. But either of these, you'll find don't cross the blood-brain barrier, just working on the GI tract, and will slow down peristalsis, decrease diarrhea. Do you necessarily always want to jump to using an antidiarrheal, though? No. Why not? Yeah, because if it's like something infectious, like you don't want to just sit there and hold on to it, right? So frequently, this is going to be for more very short-term sort of use there. Make sure they don't have any infectious causes for the diarrhea. Interestingly enough, the diphenoxylate is actually compounded with atropine. Do you know what atropine does? Actually, it's an antimuscarinic. It blocks acetylcholine receptors on the blocks the muscarinic receptor specifically. That's actually interesting because orally you find that atropine isn't absorbed at all. And diphenoxylate itself doesn't cause any euphoria, but some patients, they would try to inject this, and so they actually compounded it with atropine, so that way if they tried to inject it to try to get a high from the diphenoxylate, they'd actually feel so miserable from the anticholinergic poisoning, they would never want to do it again. So it's another kind of way to try to deter abuse that a holdover from a very long time ago. But anyway, you always want to be careful. Obviously, constipation is the main side effect you would see with this, and be careful with any infectious causes. Bismuth also does help. This is actually a pretty good antidiarrheal if they do have an infectious issue going on here. You'll find that the subsalicylate is going to have some anti-inflammatory activity, and the bismuth itself actually has some anti-intestinal secretion activity, has some antibiotic activity as well. So that may be another thing you'll see used occasionally for like traveler's diarrhea, things like that. All right, so any questions on that section? All right, so let's talk about inflammatory bowel disease, irritable bowel syndrome, sort of that whole section there. So we're going to focus on IBD first. And again, this is mainly going to be more of an autoimmune sort of condition. Have you talked about this yet with? Yes, Professor Sullivan? Sorry, I always have to think. Not Professor Rachel, because that's not very respectful. Right, so we have IBD kind of falls into two main categories, right? So we have ulcerative colitis and Crohn's disease. And again, think about this as an autoimmune condition. You'll find a lot of bleed over in terms of pathophys and also the drug therapy that goes along with it in terms of like RA, when we talk about that later on, right? So obviously the main differentiator here, at least for our purposes, in terms of which medications we're going to use, ulcerative colitis, obviously it's going to be more located to the colon, right? Versus Crohn's disease tends to be more diffuse, right? It can kind of be everywhere. And so you'll find that in terms of dosage forms that we're going to be using here, you'll find that that can actually play a big role in terms of what they actually are diagnosed with. So again, they're having this inappropriate immune response to their GI tract. You're finding you have a lot of different effects here. So again, there's a lot of inflammatory cytokines like interleukins and tumor necrosis factors, and all kinds of things are helping to stimulate this immune reaction to your own cells, right? And so you can already imagine, like, what are some things we could use to maybe help decrease that autoimmune response? Yeah, like steroids are going to be a huge one, right? So a lot of times you have patients who will show up for an acute exacerbation. Steroids are like the #1 drug we're going to go with. So anything anti-inflammatory can be useful here. So as I mentioned, ulcerative colitis more located to the colon and the rectum there, versus Crohn's disease. You're going to have much more diffuse sort of effects throughout the GI tract. And again, you can find that the inflammation can go all the way down to where it can even have perforation in some rare cases there, right? So in terms of our therapeutic options for these patients here with ulcerative colitis, you have a couple options. Now when I say topical here, do I actually mean like you're applying it to the skin? What do I mean? I'm applying it into the GI tract because that's where the inflammation is, so I can apply it. And these are usually going to be rectally administered drugs, right? So things like enemas, suppositories, things like that. That's when I say topical therapy, because the drug itself is working on the actual mucosa itself. So, and of course, if you think about it, we're all just one big tube, right? So really, that's just the inside of the tube that you're treating. So you can kind of consider that topical. If you haven't thought about that before, prepare to have your minds blown when you think about it a little too much. Anyway, so we're talking about immunosalicylates are going to be useful here. Corticosteroids can be useful here. We're talking about different types of immunosuppressants, and then we'll get into a couple of monoclonal antibodies, things like infliximab and adalimumab. And then briefly we'll talk about things like probiotics, etc. In some cases you have to go with surgery, like whole parts of the bowel can be just cut out, which is unfortunate, but that could be something that is done occasionally. For Crohn's disease, though, you're going to see very similar in terms of the medications you're going to use. The only real difference is, though, is the dosage forms we're going to use, right? So, can we get away with rectal medications for something that's very diffuse throughout the GI tract? We'll find that no, that's actually not the case. Antibiotics are used occasionally, and then maybe some antidiarrheals. So our goals here, we can't try to resolve any inflammatory processes going on, right? They can develop complications like abscesses and fistulas. You want to deal with those when they pop up. That's where like our antibiotics may come into play occasionally. And then ideally you just want to get them symptoms under control, and they kind of go into remission. They're just on maintenance therapy at that point. And then when they have their flare-ups, you treat that. Usually we'll talk about the anti-inflammatories will be good at that point there. Again, you may find patients may require indefinite therapy. Sometimes they may find they can go periods of years where they're not requiring any therapy. It just depends on the patient. So getting into our drug options, first off we look at our aminosalicylates. And so the first one I have here is called sulfasalazine. Sulfasalazine is actually a prodrug, right? Prodrug just means it has to be activated, right? So this is actually one where it actually gets activated within the colon itself. It requires colonic bacteria to actually break it down into two products. It's called sulfapyridine and then 5-aminosalicylic acid. Now, salicylic acid, does it have any anti-inflammatory properties?
Yes.
Because it's a salicylate, just like aspirin would, right? So that makes sense why it would work. So it helps to reduce that inflammation because it's going to inhibit the COX enzymes, it's going to inhibit lipoxygenase. Overall, it's going to be nice anti-inflammatory sort of actions here. In terms of side effects, it's not too severe, mainly because you're going to find less sort of systemic actions as compared to some of the other things we're going to talk about later on. But certainly things like diarrhea, anorexia, abdominal pain, etc. are going to probably be the most common things you're going to run into with this one. Now, there's a couple of different options that you can come into when you're talking about the aminosalicylates. So for instance, there's things like mesalamine or 5-aminosalicylic acid itself. This one's actually just the active form of that 5-ASA. And so this one, again, working through the same mechanism here. Because there's no sulfapyridine, this one has a lot less side effects. You may find some patients will start off with this one as opposed to going with the actual combo of the two drugs as a prodrug. Now this one is going to be designed to deliver that mesalamine basically to the colon where it doesn't actually get absorbed. So again, that helps to limit systemic side effects. So it just stays right there in the colon itself. And so we can see a couple of different options we have for how we're going to dose this. And again, these are all going to be different varieties of the same 5-aminosalicylic acid, right? So I'll kind of walk through these. The dosing is not important, but I just want you to kind of get a feel for the different types of dosage forms we have available. So for instance, we have these 800 milligram DR tablets. What does DR mean, do you think? A delayed release, so basically would not release any drug until it passed through the small intestine and it's down into the colon itself, right? There's that. We'd have some other options here. So for instance, we have a 1 gram suppository. you'd apply rectally. Now, in terms of effects, how far extended up do you think the suppository would be working? Not very far, right? So if you just were dealing with the isolated proctitis, like that could actually be a really good option though. But if it was more diffuse throughout the colon, suppository may not be a good option there. We'll look at other things as well. So for instance, if a left-sided disease, an enema might actually be appropriate, right? And I'll show you a picture that kind of gives you the breakdown there in a little bit. If it's much more diffuse and it goes past the left side, as we'll see, maybe oral options are going to be better for that patient, right? So again, you have to kind of decide which one you're going to use based on kind of where the disease is. Yes, ma'am.
That somebody could be allergic to?
I believe people will have a cross-reactivity there, so you do have to watch out for that one. So it could be a good option to go mesalamine if they do have a history of sulfa allergy. So again, looking here at the different dosage forms, you can kind of see how far up that this will actually work itself. So for instance, like the suppository just works in the rectum. That makes pretty good sense, right? An enema, or steroid enema, which we'll look at in just a little bit, more of the distal colon. And then as you get into your more oral agents, you're going to see they're going to be working more diffusely throughout the GI tract there. Okay, make sense? Kind of think about where it's going. Think about how far the drug is going to be able to work itself. Because again, with the suppository, it just kind of sits there, right? Just sits there, melts, and kind of does this thing in the rectum. Versus like an enema, there's some force behind that. You can force that fluid up a little bit higher, as we'll see in just a little bit. Other options that may work for your patients as well include osalazine, which is actually just a dimer of mesalamine. Anyone know what that means? A dimer? Just two of them pop together, right? So that's actually still considered a prodrug. So the colonic bacteria will cleave that, turn it into two molecules of mesalamine. And then basalizade's going to be another one that actually has an inert carrier molecule in the 5-aminosalicylic acid. So it just depends on what the patient's responding to, what the insurance covers, etc. So next off, we're going to talk about the corticosteroids. So ideally, we'd like to use something that just works locally and doesn't have a ton of systemic action, right? It's always going to be beneficial when it comes to corticosteroids. Because what are you worried about with systemic corticosteroids? Immunosuppression, what else? Glucose levels. It's good for the bones? Not really, not chronically, right? What else? Cataracts, whereby intraocular pressure increases. A lot of options or issues that happen here. So by using a topical corticosteroid, and when I say that, I don't mean again to the skin, but I mean directly applied into the GI tract itself, this can help to limit a lot of the systemic effects. And if you recall, back when we talked about derm corticosteroids, remember what's kind of like the weakest, wimpiest corticosteroid we had? Hydrocortisones. You see that most of our topical ones here are going to be pretty similar to that. So for instance, a lot of the ones we have are going to be hydrocortisone based. So you have like a suspension enema, suppository, there's rectal foams you could administer there. And again, don't memorize how each one of these comes. I just want you to realize, and if you were to pick a dosage format on a test, which one would be most appropriate. So for instance, if I asked you a test question and I said, hey, patient has left-sided colitis, which one of these would be a good option? You wouldn't want to pick the one that was a suppository, right? So those are kind of the things I want you to think about, and I would give you that information in terms of what the dosage form is for each of the drugs, right? Not going to be that mean and say, well, did you remember that topical hydrocortisone comes as a rectal foam? No, I'll probably just say it on the actual name itself. In terms of oral corticosteroids that can be used here, budesonide is actually a good one. This one has really high first pass effect. So what does that mean for systemic absorption? Or systemic exposure, I should say. Very limited, right? Because the liver is going to metabolize most of it, so you actually don't get much absorption there, very little effect. So budesonide might be a good option there, but in some cases, if you needed something a little bit stronger, maybe someone working a little bit more systemically, this is where things like prednisone, methylprednisolone can come into play. Certainly, if they're having like an acute exacerbation, they're coming into the ER, for instance, giving them IV corticosteroids is probably going to be your go-to for the most part, just to get that inflammation down, get them kind of in remission. Methylpred's probably going to be the most common one you're going to run into, and from that standpoint. Obviously, things like weight gain, edema, glucose intolerance, all going to be seen more with systemic corticosteroids. For the most part, with topical administration, you're not going to see a whole lot of these effects here unless you're using really high doses or just retaining it for really long periods of time. All right. Next off, we have some immunosuppressants, and so these are where we're going to get into means of trying to decrease the activities of the immune system, and usually this is going to be working through decreasing the replication of a lot of those white blood cells, right? Specifically with our thiopurines and then with methotrexate in particular. So, for instance, anyone remember how methotrexate works? I know most of you repressed that memory from last semester. if I stimulate that hippocampus just a little bit, the memories will come flooding back. Right? Someone said though, it's a folic acid antagonist, right? So if I can't use folic acid, then I can't produce things like thymine, right? I can't produce those base pairs, and I can't produce new DNA. Thus, the white cells do not replicate, right? So again, decreasing DNA production helps to decrease replication of those cells. Now, if you had to compare like the dose of methotrexate, say for instance for ulcerative colitis versus for leukemia, which one do you think had higher doses? Yeah, leukemia for sure, right? Because again, I'm trying to get rid of all those white cells versus here, I'm just trying to tamp them down a little bit. And so much lower doses, much better side effect profile than if you were using really big doses for cancer, for instance. But remember methotrexate, you got to watch things like the renal function because we do know they can precipitate out or cause interstitial damage. So you got to watch that, make sure they can clear it well. And then we know things like hepatotoxicity is an issue, myelosuppression, and anything that's going to be suppressing your immune system, you got to worry about infection, right? So be wary of infection for these patients. So it will be a bigger risk. Okay. The thiopurines, we've already seen these, at least one of these before. We saw 6-mercaptopurine. We were talking about cancer treatment, but azathioprine would be another one to fit into this category as well. Remember, these take time to work for the most part. These are kind of modifying the course of disease, and they take time. So 3 to 6 months or so before you really see full effects out of a lot of these medications here. You get myelosuppression being the biggest risk for most of these. Okay. Cyclosporin's a new one. Actually, no, we've seen cyclosporin before. Anyone remember where? We used it in the eye for, no, not glaucoma, for chronic dry eye. Remember that Restasis was the brand name there? That was the means of using cyclosporin to decrease the immune activity. You'd use it for like a lot of it, like if you had like lupus or other kind of autoimmune conditions that were causing dry eye. This is doing the same thing more systemically though. And so again, this helps to inhibit release of interleukin. And if you decrease interleukin 2 release, that's going to decrease the amount of T cells to get activated. So similarly having a myelosuppressive sort of effect there. Most of these you're going to see, so things like azathioprine, cyclosporin, you also frequently see these used in transplant medicine, which I don't touch on specifically here in my course. But why do you think you use this in transplant medicine? Yeah, it prevents that graft versus host disease where basically the body's trying to reject the foreign material. This helps to decrease the activity there. So if you see someone with cyclosporin, it could be related to, you know, say kidney transplant or something, or it could be related to an autoimmune condition like this, right? Okay, so moving forward. So here's a couple of monoclonal antibodies you can use occasionally for treatment of things like ulcerative colitis and Crohn's disease. So here we have infliximab, and then we have adalimumab or Humira. Again, usually the brand names are just easier to say for the most part, but these are have some trade-offs, right? So these are pretty beneficial for the most part in terms of their activity. They're monoclonal antibodies targeted against specifically tumor necrosis factor alpha, right? So instead of like working on the replication of the white cells, this directly targets that inflammatory cytokine directly. So in terms of onset of action, these are pretty quick as compared to like methotrexate, for instance. But there's going to be some trade-offs here. So how would I administer these? What route? It have to be by injection, right? Because they're proteins, so I can't take them orally. Okay. Versus like methotrexate, cyclosporin, those are totally fine orally administered. So that's one drawback. What do you think is another drawback to these medications? Anaphylaxis risk, for sure. What else? Mucho expensivo. They're quite expensive, right? Thousands of dollars. It's funny, we're doing a new program with our GI docs where basically the company that made Humira was coming in, and they would basically, if you had to say like a new diagnosis or a patient was switching from say infliximab over to Humira, one of the benefits of Humira is it comes as a pen that the patient can inject themselves at home versus infliximab. It's chimeric, so it has more risk for anaphylaxis and things like that. We have to bring them into the infusion center to administer. But with Humira, we had this program with the manufacturer and say, okay, well, we'll let you guys have the first dose for free to start the patient in-house, and then when they get discharged, we'll work with them and get their insurance all set up, and then we'll pay for it. You know, the patient will then be able to acquire it. I said, so we're giving the first hit for free, and then they got to pay. They said, yeah. I said, we sound just like drug dealers. They said, yeah. We're big pharma. I said, okay, that works. Anywho, so with this one, again, it's nice because, again, they can administer sub-Q at home. They don't have to worry about IV infusions. Anaphylaxis risk is going to be less because this adalimumab itself is more humanized than something like infliximab is more chimeric. So kind of some drawbacks to either one here. But also, if you look at the dosing frequency, what do you notice? you can go weeks and weeks between dosing, which is nice. The half-life is pretty long for these drugs here. And so, for instance, with maintenance therapy of Remicade, I can give it every 8 weeks. So they don't have to come back once every 2 months or so. So that can be beneficial from that standpoint. It's kind of one and done kind of infusion deal for that. So we talked about some of the side effects. Remember, what do you got to test for before you start patients on these? TB, why is that? If they have a latent infection, and you don't test for it, it can activate when you suppress their immune system, right? So this is why you got to test them for TB beforehand. This is going to be more likely with these, but it certainly could happen with other immunosuppressants, but this is the most common thing. It has a black box warning on it, so you just got to do it. Because if you did start a patient on one of these and then didn't test them and then they had TB and they died, that's on you, right? Because you didn't test them beforehand, so we got to be really careful with that. Are some risks for things like secondary malignancies, but again, the risk is fairly low. Again, you got to look at the risk versus benefits here. So most part, they do pretty well with these drugs. In terms of probiotics, you can probably do a whole elective on just probiotics themselves. There's so many different varieties that are out there, and it's really hard to do good studies to do any kind of like head-to-head comparisons, any kind of control groups, anything like that. It's really, really tough from that standpoint. Basically, what's the concept behind probiotics? Yeah, we give them good bugs to outstrip the bad bugs and get rid of those, right? Or if we're disrupting the bacteria and we've lost some, we can try to make sure we repopulate with good stuff, so that way you don't have any kind of pathogenic bugs start to kind of take hold, right? Some people feel this can be beneficial. I mean, some people even feel like changing the microbiome have led to things like ulcerative colitis and Crohn's in some cases there. But again, there's a lot of conflicting studies, so there's nothing to say necessarily, yeah, you have to do it or you don't have to do it, so it just depends, right? So again, no hard and fast rules there. In terms of antibiotics, some possible benefits here could be if you did have any kind of pathogenic bacteria, if you're developing any abscesses or anything like that. This can be helpful here, and so this is going to be more seen with like patients with fistulas that happen in Crohn's disease or any kind of like small intestine like bowel overgrowth, things like that. Typically, what type of bugs are going to be growing there in the GI tract? Anaerobes and gram-negatives, right? So you're thinking about your enterogram-negatives, thinking a lot about anaerobes. So this is why we use things like ciprofloxacin, metronidazole are going to be pretty good options there as well. Other people try things like clarithromycin, tetracycline. Rifaximin is another one that kind of fits in the same category as rifampin, but we don't use that as commonly. But typically cipro, metronidazole are typically the common ones. So to more focus it just specifically on ulcerative colitis here, we can see that our goals, obviously, again, get remission, get them under control, and then get them on maintenance therapy to try to prevent further episodes from occurring there. And again, as I mentioned, the treatment is going to be dependent on the severity and that location of the disease itself. So for instance, if you're looking here for just a proctitis itself, what's going to be good? What type of dosage form? Like a suppository could be useful here. The further up it goes, you're going to require something like an enema, right? So again, if it's just left-sided, and again, why is it hard to kind of get over this hump here and cross over the rest of the colon? It's gravity, yeah, right. Gravity's going to pull everything down. So because of that, if it's more diffuse than that, it's going to be covering the entire colon. That's where the oral options are going to be more preferred, okay? And so if I would ask a test question, I'd make it pretty clear in terms of like where the disease is and what type of dosage forms you have available to you. You might have to make a distinction on that.
You can't prescribe like an inversion table or something?
I guess you could, but I don't know if there's any clinical trials looking at use of those tables or not. I mean, you can just like kind of, you get like a really strong guy to like pick up your patient or a strong lady and pick them up and wiggle them around, who knows. Because we do that sometimes for like, surfactant for little babies. They're born prematurely, sometimes we'll move them around, get the surfactant all in the lungs, but no, I don't think conversion tables will be good for these patients here. So looking at your different options here, right? And so again, you always want to think about kind of a stepwise approach for this. And most of this is pretty common sense for the most part. So again, looking at the disease severity is going to kind of dictate how hard you're going to go in the very beginning. So for instance, they're coming in with like, say, a severe fulminant disease. This is their first diagnosis, for instance. Again, you can start off with things like IV corticosteroids, right? Just to get things under control and then step it back down. For the most part, if it's more mild to moderate disease here, you see that typically you're going to start off with some kind of aminosalicylate-based product, some kind of mesalamine-based product you're going to start for these patients here. And the dosage form is going to be based off of basically where the disease is located after they do colonoscopy or something like that. Typically, with the more severe disease, that's where you want to introduce the immunosuppressants, right? Because again, more side effects associated with those, immunosuppression, etc. And so those are those cases there we want to start including things like azathioprine, mercaptopurine, etc. Again, if patients are maybe having side effects from those, or maybe they're not working so well, that's where you can start to incorporate things like your infliximab, your adalimumab. There's some other mAbs that are out there as well, but I kind of cover the common ones, and kind of see where they're going. Once they kind of get things under control, you can try to scale back dosing. So specifically, if they're on pretty high dose corticosteroids, scale them back if you can, and see how they do with it. Okay, so again, go by a stepwise sort of approach for these patients. Make sense? Okay. For Crohn's disease, obviously, what kind of dosage forms are we using for these patients? Only oral stuff, right? Because again, it's going to be much more diffuse throughout the GI tract, and so because of that, the treatment's going to be largely the same, but the dosage forms are going to be more straightforward. Here you're going to see that you may introduce antibiotics, though, right? So that's going to be something to consider with these patients, either including metronidazole or ciprofloxacin in that sort of batch there. These patients typically require, for more moderate disease, kind of oral corticosteroids more frequently. So you'll see that pretty common. They may be on like prednisone 40, Q daily, things like that. And then again, immunosuppressants, monoclonal antibodies, all these can be useful as well to see kind of how they do. Ideally, which drug would you want to taper off of first for those patients? Steroids. Steroids are always going to be the first thing you want to taper off of if you can. Okay, you can get them off the immunosuppressants and just have them on the anti-tumor necrosis factor drug. That may be beneficial for some of them, right? That kind of makes sense. So again, if I asked you, like a patient was on, say for instance, they were on mesalamine, and then for say a left-sided colitis, what would, and their symptoms are not under control, what would you add on next? Again, you want to think about things you kind of bump up to, like an immunosuppressant might be reasonable, a monoclonal antibody might be reasonable. Those are kind of stepwise approaches I want you to think about. Okay. And as I mentioned with maintenance therapy, obviously once you kind of get things under control, this is where you're going to try to see, preventing, exacerbation of symptoms. Ideally, for a lot of patients, you can see that with like Crohn's disease, they may be on just methotrexate antibiotics by themselves. In some cases, you may find that. Also, for colitis, so again, it's going to be dependent on kind of where the disease is. Typically, corticosteroids, that's a CS, no role maintenance therapy. So try to wean them off that as best you can. Again, those are the patients that need a taper typically. Most of the time, they're going to require a taper because they're probably going to be on it more than a week or so. So you're going to need to go ahead and make sure you kind of build in a taper to prevent what? Adrenal insufficiency, right? Absolutely. Don't want to cause another problem on top of that. Okay. I'm not going to keep going. I'm going to leave irritable bowel syndrome for next time. So hopefully it doesn't irritate anyone's bowels to stop further. Let me see if there's any questions. This one's just blank. I like blank question. Maybe a stupid question, but if bismuth subsulfate is relative of aspirin, how does it have a pro-prostaglandin effect? It tends to be just kind of a local activity. I don't know the full mechanism. I'm sure someone has elucidated that elsewhere. I don't know, but it does work for H. pylori, so I'm going to keep going with that. Sometimes you don't have to know everything, but you have to know some stuff. Any other questions or anything before I let you go? Wonderful Friday afternoon. All right, I'll see you guys next time.